so you're going to do by the symptoms, but then usually the provider will go ahead and do a monospot, just to make sure it's nothing else. So that's another diagnostic test. There's a blood test they can do, and then it gives you a pretty quick result. And that way you know you're just going to treat it with symptoms, which again, since it's a virus, we're not going to give them aspirin. Bed rest is your biggest thing. Fluids. So I talked about the spleen being enlarged. They will go and see the provider after they're not sick anymore and make sure that spleen has gone down. Because until it does, the contact sports or anything like that, rough housing, that kind of thing, it can rupture the spleen, and that's bad. And you want to avoid live vaccines for several months after. You want to make sure they get the immunities built back up. Oh, the flu. I already had my flu shot. Got it last week because with everything going on right now, it's just a good idea to go ahead and be covered. And we're going to look at types A and B. There is a C, but we don't usually vaccinate for it. It's not as serious, so we usually just vaccinate for types A and B, and then they figure out which ones are going to be the most serious that year. That's why it changes every year. Did I tell you 897 is the page on that one? Yeah, 897. And here's the kicker, because it's going to say, what does it look like? Well, it looks like everything else. It's got, the dry cough, low-grade fever, headaches, fatigue, just don't feel good. Children are more apt to have the nausea and vomiting, but adults don't usually. It's a self-limiting. All of your viruses are usually self-limiting. They run from 7 to 10 days, and then you're over it. But you can get other illnesses from the flu. So that's why we talk about this more. You can be infectious 24 hours before you start running symptoms and 5 to 7 days after symptoms. So that means you can have the flu and be out at the grocery store or wherever else and be spreading it. And it is respiratory droplet again. We know what that means. You're going to treat the symptoms. The prevention is the biggest thing, and that's going to be get a vaccine. Get your vaccine. And there now, pediatricians have actually agreed that children 6 months on age on up can get the flu vaccine because we want to protect them too. Also prevention, hand washing, staying away from people that might have the flu, but your frequent hand washing is going to help. And hope that the scientists get the right strain that year on your vaccine. So here's your medicines. So they have an antiviral that you can take, the Tamiflu and the Relenza. Those must be started within 48 hours of symptoms. It does cut it short by a few days, which when you're sick, that's not a bad thing. And avoid aspirin. I've said that already, but avoid aspirin. A new what? So one of the students said they've come up with a new medication. I'll have to find out about that. That came out a few years ago that you take 2 of them and it stays in your system for 2 weeks. Thank you. There you go. He works in a pharmacy. We got sources. Roseluza? Zofluza. Oh, I've seen that on TV. Okay. Okay. Very good. Does it work? Okay. They say it's more effective than the Tamiflu. That's interesting. Okay. How expensive is it? Okay. Not terribly expensive. Okay. I'm always curious about that because when the new ones come out, they try to make up their research and development costs by charging an arm and a leg. Okay, so recommended for children greater than 6 months. There's a new vaccine annually, injected and inhaled. The inhaleds have never been that good. We usually just do the injectable kind. If you're contraindicated to the flu vaccine, then you can't take it. Epidemiology, value of influenza vaccines in pediatric population. Later on, we're going to talk about the diseases they can get because of the flu. So the flu, we always go, oh, it's just the flu. But the flu can cause other problems. One of them is otitis media. So here's your, because it can be part of the germ that's in there. So otitis media on page 898 is fluid in the middle ear. There's a good picture on 899 of a comparison. A is the child and B is the adult. When I said it's horizontal, the eustachian tube, as they get older, it starts to drop more so that the drainage can get out. But as they're infants and children, that drainage just stays right there and sets them up for infection. You can get it from feeding, positional. You can get it from smoke inhalation. If your parents are smoking, you have allergies. It can cause more secretions, and the more secretions you swallow can stay in your ear. So that's where that connection comes from. Diagnostic, you're going to look for edema in the ear. You're going to do it carefully because you don't want to rupture the eardrum. But you're looking for it to be red and swollen and drainage in there. Most of the time we try to treat ear infections symptomatically. There was an overuse of antibiotics and found that symptomatic treatment is usually just as good and they get over it. It's self-limiting. The problem with ear infections is if they have them recurrently, it can cause some hearing loss. So, you just want to make sure that you're staying on top of that. So your pain meds, I think there's a slide that says, yes, okay, so hang on, I'm not going to say that yet. I'll talk about the medicines in a minute. So there's the pharmacological, that's how we're going to treat it with medicines. We can do it asymptomatic, we can do it symptomatically, or we can do it with antibiotics. And then there's the surgical. And the surgical is putting the tubes in, but they can also go in there and do this thing where they cut a little bit into that myelomeninge thing, I can't pronounce it, and that allows some of the swelling to go down. They can do that in the office. Nursing considerations, you want to prevent infections. So if you see a parent coming in and their child has ear infections, you're going to start right then. Actually, you can start when they come in the first time for their well baby checkup if you're working in a clinic or if you see them in the hospital. And you can just start telling them to position them with their head elevated so that it allows the drainage to go down. If they have a cold, elevate the head of the bed so that they can get that drainage out. I had terrible ear infections when I was growing up, so I know how painful it is. Make sure they know to take all of their antibiotics. And there are some immunizations available for the pneumococcal vaccine because they believe that the pneumonia is also one of the precursors to the ear infection because of the secretions. Okay, so this is just a comparison of what they do. So breastfed babies actually have less otitis media than bottle fed. I can attest to that. My son was bottle fed and had tons of ear infections. My daughter was breastfed and never had any. That is not scientific, that's just from example from me. They get the immunoglobulin A from the parents, and the position of the breastfeeding is where the head is actually elevated better. Antibiotic therapy, we usually wait, if they're over 6 months, we wait to make sure it's going to resolve on its own. After 72 hours, we're going to treat the symptoms. If not, then we say, bring your child back in 3 days if he's not better. That's why the providers will say that. If the baby's not better in 3 days, bring back, we may have to start him on some antibiotics. Less than 2 years with persistent acute symptoms of fever and pain, we're going to go ahead and give them antibiotics. And if they're less than 6 months. And then there are some benzocaine drops that they really do help. I actually had an ear infection as an adult, and my husband taught me to pop my ears open because it was trying to get infections again. So if you ever do that, you can pop your ears open and that actually relieves it. But the benzocaine drops actually does deaden that pain in there, and it feels a lot better. Do you guys still sell that at your pharmacy? Maybe it's it says prescription, but I saw it over the counter. Ear infections. Okay, so this one I wanted to explain just a little bit. We've just talked about a lot of it, but it says otitis media with effusion. Effusion simply means fluid without infection. They just have fluid in their ears. Okay? So it's comparing them, those that have, and then it's got the otitis externa, which is the swimmer's ear, that's the outer part of the ear. That's usually from swimming. Those are the older children. They're swimming and they don't clear out their ear afterwards. There are some preventive things you can do. You can, in your book tells about it, I'm not going to tell you how to do it, but you can put some certain drops that you can make at home that you can put in the ear that help dry up the water. You don't need to know that. Just know that we're going to be instructing the parents to help that child keep the ears dry after they're done, if it's the external one. And then we're going to make sure that they're taking for the otitis media, for the middle ear, we're going to make sure they get vaccine, that the breastfeeding is best if you can, or positioning with their head up if they can't breastfeed, and prevent exposure to tobacco smoke, because that is a huge allergen for children. And make sure they know that with repeated ear infections, we can get hearing loss, so we want to make sure that we're doing everything we can to keep them from getting another one. We're cutting back on the exposure, we're cutting back on the positioning so that they can get that drainage in, and they can, so they know that we want to prevent any other problems. Okay, so here's your antibiotics. I'm really not concerned about this, but your book has it in there. They just have their first line, which is your amoxicillin, your second line, which is these others, and then your analgesics and your antipyretics, so your acetaminophen or ibuprofen, and no steroids, antihistamines, decongestants, or antibiotic ear drops for otitis media. Group syndromes, page 903. They group all of these together. They're very similar, and on page 903, there's actually a chart that differentiates one from another, and I'm going to go through several different ones. So pages 903 to 906 is going to talk about all of your croup syndromes. They call it croup because they get a cough that sounds really, well, croupy. It's hoarse, it's barky, is what they say. They can have inspiratory stridor, which is difficulty getting the air in. They can't get the air in because there's some swelling somewhere. So now this next part on that slide, that's your anatomical position. So it's in your larynx, your trachea, and your bronchi, mostly. So depending on which area it's at, which area it's affecting the inflammation, you're going to get worse symptoms, or you're going to get different symptoms. So, and that's what it says, described by anatomic area primarily affected. We're going to get into epiglottitis here in just a second, and then all those other ones too. Clinical manifestations, it depends on where it's at, okay? So we'll cover that, and we'll cover nursing care management. So the biggest one is your acute epiglottitis, and this is when it happens quickly. It's a serious obstruction. They go to bed, they're feeling okay, but then they wake up and you hear them coughing, or they cry out, and you go in and they're sitting in a tripod position, page 903, and they're drooling, and you just take them straight to the ER. Because they have got the epiglottis has actually closed up. It can get completely closed out and they cannot get air. So this is a medical emergency. We'll cover more of that here in a second, so don't worry, I'm not done. So what do they look like? They're usually sitting up in a tripod position. They're trying to get an airway cleared as much as they can. So they are straight as a stick, and they're leaning forward, trying to get air to passage. No one has taught them to do this. They do this because they're desperate. They're usually anxious and irritated because they don't know what's going on, and they're scared. And they're drooling because they can't swallow the spit. Their epiglottis is red. They will probably be intubated. So when they come in, you're going to make sure that you have the emergency equipment right there. And then they're going to start them on antibiotics and probably some steroids to decrease the swelling. So the nurse's job when that patient comes in is you're going to act quickly but calmly, because you want the parents not to get you know about the ages of the children. If the parents get upset, the child's going to get upset, and then the child's not going to be able to breathe again. So we want to make sure that we keep the parents calm and that we provide quick action. It is passed by a droplet, so you're going to make sure that you are masked and all that stuff. And once they get them intubated, once they start the antibiotics, they're fine after, they're not contagious after 24 hours. The provider is going to actually look, that's why I kind of grimaced when I said the epiglottis will be red. You're not going to look at it because you could send them into a bronchial spasm or a spasm where it closes off and then they can't breathe. You're going to get the provider in there to look at it, and they're going to have the emergency equipment probably in their hand just to make sure, and resuscitative equipment handy. It's caused by Haemophilus influenza B, so they can get the Hib vaccine. And that prevents most of it. That prevents it. So what is your job? Again, we're going back to that other slide, not slide 18, but the one after that that said, you know, how do you know if a child is having respiratory distress? So position for comfort, head of the bed is up. Decrease their anxiety, you're going to keep calm. No tongue blade, because you don't want to cause that spasm. Suction is going to be by the bedside because they can't swallow the fluid. And you're going to help them get it out so you can suction in their mouth. And then have your emergency respirator equipment at the bedside. Page 904 is your acute laryngitis. Now we're moving down the respiratory tract. More common in the older children, usually caused by a virus. It's a virus, so it's self-limiting. It's going to last from 7 to 10 days, and then it's going to go away. It is a sore throat, but it's not as severe. They don't feel as bad. They're not positioned because they can get their breath. It's not as swollen. That epiglottis, and you can Google that and look at pictures of it. They have where it's just almost completely closed, and they have it, you can look at that, see what it looks like. It's pretty freaky. But the larynx is a little bit more open, so they don't generally have that. So you're going to treat them symptomatically. And again, we're going to add the humidified cool air helps with the swelling, and so that is another thing to have handy. Okay, so here's your signs of increase. I thought we already covered this. So this is your signs of increasing respiratory distress, because we just looked at acute epiglottitis and then we looked at laryngitis. So how do you know if they're having trouble? Well, their restlessness gets higher. They're irritated. They're fidgeting because they suddenly something has changed, but they can't vocalize it usually. Tachycardic, their heart rate's jumping up. Tachypnic, they're breathing fast but shallow. Retractions, because they can't suck in the air enough, and so they're going to have some retractions. So the substernal, suprasternal, and intercostal just is how it looks like on the actual child. So if they're having signs of distress, we're going to position them and prepare for oxygen if needed. Okay, page 905. Again, this is viral. Acute spasmodic laryngitis. We're moving on down. Midnight croup. This is the one where your child goes to bed, they feel fine, they wake up with a cough, they sound funny, and then in the morning they're fine again. It is self-limiting. They have noisy inspirations because there's a little bit of swelling, but not terrible. They're restless, but they don't really have much of a fever. This is generally in children ages 1 through 3, the younger ones. Symptomatic treatment. So how do you know in a test question which one it's talking about, right? Look at the condition of the child. In the question, it will give you what the child looks like or what is going on. That will tell you what your next job is. You don't have to diagnose which illness it is. You just have to respond as a nurse. Are they having trouble breathing? We're going to elevate the bed. How's their pulse ox? Oh, it's 85. We might want to get oxygen ready. Are they swallowing okay? No, they're drooling. Oh my gosh, we're getting a provider in here and we're going to prepare for intubation. So as a nurse, you're not diagnosing, you are preparing to act. You're looking at them, assessing them, and acting that way. So when you look at these different diagnoses, the different groups, because there's lots of them, figure out where it's at and what is the child doing? How do they look? What's their clinical manifestations? And according to their clinical manifestations, that's what you're going to respond to. Don't add things to the question. Okay, this is page 906. And the reason this one is after the laryngobrachial tracheitis is because it's usually preceded by that one. They usually start off with that and then it gets lower. So now we have bacterial tracheitis. It's an infection of the mucosa of the upper trachea. They're going to have thicker, purulent secretions because it's bacterial. They're going to look sicker. So that's why the bacteria has set up in here. Their secretions are now looking purulent. They don't look, they're thicker. Respiratory distress and stridor. They're going to have trouble breathing, and they're going to have that stridor, which is that high-pitched noise. Look that up on easy auscultation. They may develop life-threatening obstruction or respiratory failure. May. Therapeutic, we're going to your book says nursing is vigorous management of antipyretics, fluid, and antibiotics. Because it's bacterial, we're going to treat it with antibiotics. But we're also going to make sure they're getting fluids. We're getting that temperature down because that's causing that child or that teenager to feel bad. If it progresses, if the swelling progresses and they can't breathe, we're going to prepare for intubation. Okay, infections of the lower airways. I'm going to go ahead and cover a few of those today because I have a little bit of time. Page 906. This includes the bronchi and the bronchioles. It says this is a general overview. Cartilaginous support not fully developed into adolescence. That just means that part that's being affected is not strong enough. It's not developed enough, and they can have constriction of the airways. Bronchitis and bronchiolitis. We've moved on down the airway thing. It is an inflammation of the large airway. So when they're breathing in, they can get air all the way down their pharynx, but now it gets into the chest area and it's harder to get that air in. Okay, so they visualize that. It's usually caused by viral flu A and B. Coronavirus. That makes you look up, doesn't it? You know there's more than one. This is a different one. This is not COVID-19 that we're experiencing right now. This is a different one, usually types 1 through 3. And RSV. We'll talk about that here in 2 slides on RSV because, like I said, this is RSV season. It starts off as a dry hacking cough. They can breathe, but now there's inflammation in their airways. So they're coughing, trying to get that up because it's moved on down the airways. It's usually non-productive and it's usually worse at night. Self-limiting, because it's a virus, it's gonna last 7 to 10 days. We hate that. We want them to be better quicker. But if it's a virus, we're gonna treat them symptomatically and watch for any other problems, okay? And like I said, this one's primarily caused by RSV, which is our next slide. So respiratory, I used to call it rhino, it's respiratory syncytial virus, RSV, is the virus that causes the bronchiolitis or the bronchitis, okay? And it's very, very, very contagious. Most children have had it by the time they go to school, but the little ones haven't. They're the ones that get it and get sick and sometimes have to be hospitalized. So what happens is they get air trapping. They can't get the CO2 out. So they can breathe in, they're not making the exchange, and the CO2 can't get out. So they're getting sicker, unless our symptomatic treatment helps them get better. But a lot of times they do have to go into the hospital to get that intervention. Usually the younger the client, the worse, because they haven't had anything like that. They're not as strong. They don't have as good an immune system. They have weaker coughing muscles. All of that stuff interact to make them not be quite as able to fight it off. So that's why we see a lot of younger ones in the hospital with it. It is by aerosol. It can direct transmission with respiratory secretions, but here's the kicker: it can live on surfaces for hours. It is very, very contagious. So what does it look like? If it's getting worse, you're going to start seeing respiratory distress. They're going to have wheezing, retractions, crackles in the lungs, dyspnea, tachypnea. They can even have diminished breath sounds. So from those manifestations, you can see what the nurse's job is to be. We're going to be assessing. If they're in the hospital, we're going to be doing a focused respiratory assessment every time we walk in that room. What do they look like? What's their work of breathing? How do they look? Are they pink? Are they coughing a lot? Can they get the fluid up? Most of them can be managed at home, so you're going to instruct the parents to give them the antipyretics, to help them with cool mist humidifier, all those interventions that we looked at on slide 18. Because of the respiratory part of it, they're having trouble breathing, they don't want to eat. So in hospital, we're going to make sure they're going to probably have an IV. They're going to have poor nutrition, so we're going to make sure we're supplementing that with something that can give them some calories. And now here is the exception to the cool mist. When they're in the hospital, in order to help them with RSV, get that air all the way down to the bronchioles, it says in your book they're going to use heated, high-flow nasal cannula. That is the exception because, remember what I said, if you use a vaporizer that's warm at home, the problem comes from the vaporizer getting bacteria in it. In the hospital, we clean them. And it's meticulously cleaned, the equipment, or it's not used again, they get a clean one. So for this child, they're going to need the heated, moist air into their nasal passages so they can get it all the way down. To help the child be able to eat better, you're going to suction the nose and the mouth so that they have that clear passageway so they can actually breathe when they're eating, because that's so frustrating. They go to eat and their nose is clogged up, they just cry. It's just real sad. You can go ahead and suction tracheally if you need to, but that can be traumatic, so we try not to do that unless we just absolutely have to. We want to make sure they can cough it up. They're probably going to have some respiratory treatments, but this is not included in yours, but they usually do. And they have that little shaker vest that makes them, it jiggles them around so they can cough things up better. You diagnose it with the nasopharyngeal secretions, and you can get a rapid test on that, and it tells them whether or not they have RSV. All right, let's look at pneumonias. Okay, your next several slides talk about pneumonias, so I'm going to break it up for you just a little bit. Just know that they're telling you that there's lots of different kinds, and the different kinds will have different symptoms. So don't freak out when you see all the different slides, okay? We're on page 909 to 913 is where all those go. So usually what we see is viral, which is going to be treated symptomatically. Atypical, that's actually combined into your community one in your book, and we'll talk about that a little bit. And then your bacterial, which is your antibiotic treatment. Usually the viral will self-limit 7 to 10 days. It's a virus, but because of the pneumonia is going down into the actual lungs, they're going to be tired for a couple of weeks afterwards. They're going to need more convalescent afterwards. And if you talk to elderly, it can zap them for months. I mean, they are just exhausted after having pneumonia. So that you just let the parents know they will not be up to their usual activity for a little while. Give them a chance to heal. Mild to severe, I'm going to go over that a little bit more. Bacteria, they usually look a lot sicker. Remember, they're toxic, so they look a little sicker. And you're probably going to hear when you do your focused assessment in their lungs, you listen to their sounds, you might hear crackles and congestion, fever. Your diagnostics are going to be with an x-ray, lab for sputum cultures, and you'll treat with antibiotics. That's your general slide. Now let's get to your other one. Oh, okay. Clinical manifestations of pneumonia itself, whether no matter which one it is, viral, bacterial, or atypical, and fever, malaise, they just don't feel good, rapid respirations. They're trying to get the air to exchange that O2, CO2. It's not doing it because you've got pneumonia down in the lungs. So it's not able to make that alveolar exchange, so it's affected. So they're going to be breathing faster, trying to get more air in. And they're going to be a cough, usually productive, but sometimes it's non-productive. I already talked about diagnostic evaluation. Prevention is with the vaccine. We're going to talk about the therapies and complications on the next slide. So when you look at the x-ray, how do you know what it is? So you're looking at the pulmonary infiltrates. We're looking to see, we're hoping to see nice clear lungs, but we can usually see an area that looks consolidated or it looks more solid, and that's where your pneumonia is. And you can have it in different areas. And then I've already talked about your culture, sputum, blood, lung aspiration, or biopsy, whatever they need to do to get the correct. We usually start with the simplest first, so don't write all that down. Just sputum is usually our first one in blood cultures. And then if we're still not getting anything, then we may have to go and do a lung aspiration, or we might have to do a biopsy if they have an atypical one. And white blood cells are going to be elevated. So on your other slide, let's go back to that for a second, because I wanted you to see something. Yeah, okay, so on the etiology of pneumonias, there's an interesting thing. I had never heard of this before. They have a mycoplasma pneumonia, which I've heard of, but they have a chlamydial pneumonia. Now, there is a chlamydial pneumonia that's not from the sexually transmitted disease. That's what's on this slide. This other slide is the one from the mom that has the chlamydial trichomonas. This is on page 912, and it's under the neonatal pneumonia is where it's listed. They get this 2 to 19 weeks after delivery. The infected mother can transmit it to the baby via the blood or through the birth canal. They're usually afebrile, but they have a cough, tachypnea, and rales. An x-ray will give you your diagnosis and antibiotics to treat it. This is just an explanation of what that is. You really don't have to spend a lot of time camped out there.
Ms. Briggs?
Yes, ma'am.
Can we have our in-class assignment? I think we're about to cut off.
Oh, yes, thank you. I want you to go online. I want you to tell me how many respirations a newborn has a minute. That is your attendance for today. Thank you.
Thank you.
How many respirations do we expect a newborn to have? Okay, so your next slide is pertussis or whooping cough, which has been interesting to me because that didn't used to be one of those that we talked that much about, but we're seeing a resurgence in it, and they're a little concerned that they're getting, that the vaccine the babies have had, or that they've had, because there's 5 of them, is not giving them enough, that it's not protecting fully, so they want you to have a booster, so we'll talk about that. Usually in the United States, it's found with those that have not been immunized, but that just contraindicated that because now we're seeing it in older children too. They can't get the whooping cough vaccine until they're 2 months old. So that means that those little precious babies are vulnerable, and they actually suggest parents getting or in family, getting a booster. We had to when my niece had her child, the pediatrician made them all go get, or all of us go get a whooping cough if we hadn't had one booster, just to make sure. We are seeing a lot of parents that are not vaccinating their children, so that's why I think another reason why we are getting more whooping cough in the community now.
Can you repeat what age you said that you can start getting the whooping cough?
Yeah, 2 months old.
Thank you.
You're welcome. They get a total of 5 of those in their childhood, and I don't know the schedule anymore because it changes, and you don't need to know the schedule for infection lecture either because NCLEX is not testing you on the vaccination schedule, and we can all say thank you Jesus because it was horrible that you had to memorize that. But because it is a worldwide test, they don't have the same schedule we have. So they just say vaccines, they don't say, you don't have to memorize the schedule. I'm just saying these 2 months old, up to 2 months old, they're vulnerable. We want to be very careful with them. Highly contagious. And that's pretty much all you need to know. It does make them feel really bad. They do have a terrible cough. It does cause respiratory distress. TB, another one of those things that's coming up. Because there's 2 different kinds. Let me see if I have that on this other one. Yes, okay. So TB has kind of made its surgence because of the HIV positive, and people are living longer with that, but they're immunocompromised. So they can get the TB easier, okay? So it is inhaled, it's airborne, taken down the respiratory tract. It takes up shop in the alveolus or the bronchial tree, and then the cells around it try to ward it off, so they form this, basically a shell, and that's what causes the trouble. The body is trying to protect itself, and it causes some trouble for them. So what does it look like? If it's an active disease, a fever, cough, night sweats, chills, weight loss. I can say that again, but it's in your book. Fever, cough, night sweats, you get your chills because of the fever, and your weight loss. You don't feel like eating. The diagnosis is usually made with a TB test. That's that one you get where they put a little wheel underneath your arm and you see if it gets hard. If it gets hard, then you've been exposed to the TB. We'll talk about that more in a minute. And it's treated with antimicrobials. The next slide is going to tell us more. Okay. So you can have latent TB, and that means that you can have a positive TB test but not have any symptoms. You don't have the disease. But they go ahead and treat you as if you do because 5 to 10% of the people can get it just from having the latent. You've been exposed somehow, you get a positive TB test. We're going to go ahead and treat you with these antimicrobials just to make sure because you don't want to, get sick. You don't need to know about the induration, just that if it's a positive one, you do have an induration. That's not necessary to know the amount. So here is the pharmacologic. Again, you don't have to know this, just know we do give them, and it's a lot longer than your regular antibiotic or antimicrobial treatment. So you see they get the isoniazid for 9 months, and then there's a specific time period that they give it, daily or alternatively 2-3 times a week or weekly, but you're being followed by a provider. Your rifampin, you're gonna get for 6 months. Treatment not recommended for children with positive TB test result, but no risk factors. We don't need to know that. Just know that latent TB we usually treat to reduce developing the active TB. If you have active TB, here is your treatment. Again, don't memorize this, but it is a treatment. 9 minutes. So if it's active TB, you do have to be isolated. If it's latent TB, you're not infectious. Okay? So we're talking about active TB. So isolation for
Hi. I have a question.